Hello, everybody, and thank you for joining us for another episode of Meet the Researcher. Today, I'm pleased to welcome VHLA Clinical Advisory Council member, Dr. Amit Tirosh, the CCC sponsoring physician from Sheba Medical Center in Ramat Gan, Israel. Dr. Tirosh is a senior endocrinologist, a specialist in the treatment of neuroendocrine tumors, and the head of neuroendocrine tumor services for the Institute of Endocrinology at Sheba Medical Center. Dr. Tirosh specializes in inherited syndromes related to the development of neuroendocrine tumors and is considered an expert on VHL. He is able to provide his patients suffering from neuroendocrine tumors with cutting-edge medical treatment. Dr. Tirosh conducts active research focused on the bioinformatics of endocrine cancer in general and of neuroendocrine tumors in particular. He maintains active collaborations with research groups in the United States, Italy, Germany, and with researchers from the Weizmann Institute of Science in Israel. Dr. Tirosh, thank you for being here.
Hi, Joe. Thank you very much for this very kind introduction. I think we might better stop here then. I would like to thank you, Dr. Zassman and Heidi, for the constant activity in the VHL Alliance and you for organizing this talk. And I'm happy to start talking about pancreatic neuroendocrine tumors in the context of VHL. So we're going to talk today about VHL-related pancreatic neuroendocrine tumors. I will briefly discuss some of the research updates from the last years in this specific field of pancreatic neuroendocrine tumors in patients with VHL. Then I'll describe the collaborative VHL clinic that we established at Sheba Medical Center. And very briefly, some of our international collaboration from the VHL Center here at Sheba and through several projects. So very briefly, a few words about neuroendocrine tumors. Neuroendocrine tumors are a very unique type of tumors, very different from other types of cancers that arise mainly in the lungs, in the small intestine, and in the pancreas. And now I'm not talking specifically about patients with VHL. When we're talking only about pancreatic or only about neuroendocrine tumors in the gastrointestinal tract and in the pancreas, the pancreatic net accounts for about 15 to 30% of all the gastroenteropancreatic net. And the pancreatic net are characterized by heterogeneity. They're very widely between each other and between different patients. And there are several parameters that they are heterogeneous by. First, the grade of the tumor or the aggressivity of the tumor ranges between very slow growing, what we call indolent tumors, to very aggressive ones. Second, pancreatic net, again, not in the context of VHL, can be localized and tend to keep localized, and on the other end can be metastatic to lymph nodes, to liver, and to other organs. Last thing is that they can differ in their functional status. Pancreatic net and other types of neuroendocrine tumor can secrete hormones and other compounds that lead to clinical syndromes, such as low blood glucose, stomach ulcers, and diarrhea and other symptoms. And some of the pancreatic net, again, not in the context of VHL, can have functionality or lead to clinical syndrome, and others might be what we call non-functional pancreatic net. And my main question now is whether the VHL-related pancreatic net are similar to other non-hereditary pancreatic net, to the main group of the pancreatic net. And the answer is no. And we can answer this question in two parts. First, when we're looking at the patient characteristics, the second one, we're talking about the tumor characteristics. When we evaluate patients with pancreatic net, there is a huge difference between evaluating patients with pancreatic net in the context of VHL and pancreatic net in any other context. When we are looking at the CT scan from patients with VHL and we see lesion next to the pancreas, we must suspect other origins for the tumor, such as the kidney, the adrenal, and not only the pancreas itself. If you have patients that has only pancreatic NET and do not have VHL in his medical background, then the risk for additional tumors is extremely low, and the approach will be completely different. When we consider surgical resection of pancreatic NET, again, there is huge difference between patients with a pancreatic NET with no VHL and patients with VHL and pancreatic NET. For several reasons. First, a patient with VHL that developed one pancreatic NET has high risk to develop a second or third one during his or her lifetime. And we have to consider this because if we are going to resect the tumor, we have to leave more functional tissue behind us. So the patient will have more reserve pancreas for next surgeries. The second thing is that patient with VHL, and you, the patient, know this very well, you are always candidate for some type of surgery, either for the hemangioblastoma, or for the pheochromocytoma, or for the kidney tumor, or for the pancreatic tumor. And we always have to consider very carefully whether the surgery is justified or not. And these considerations do not exist in pancreatic NET that are not in the context of VHL. And the last thing that when we consider whether to intervene and how to intervene when a patient has a pancreatic NET, we have to consider the relative risk from each of the tumors that the patient has. And we have to think whether the kidney tumor is more important now, or the pancreatic tumor, or the pheochromocytoma, or the ear lesion, or the cerebellar hemangioblastoma. So we have to take much more parameters in our calculation when we make any clinical decision. When we're looking at the second part, when we're looking at the tumor characteristic, again, they are very different from the characteristic of the non-VHL-related pancreatic NET. First, in general, there are always exceptions in medicine. But in general, the pancreatic NET in the context of VHL are of low grade, very low aggressivity. They tend to go very, very slowly. The second point is that the risk for metastatic disease in patients with pancreatic NET in the context of VHL, compared with patients with pancreatic NET not in the context of VHL, the risk for metastatic disease is much lower in VHL-related pancreatic NET. We're talking about 10%, I'll talk about this more later, but we're talking about 10% risk for metastatic disease when a patient had a pancreatic NET, and much higher when the pancreatic NET is not in the context of VHL. The last thing is, again, the functionality, and in VHL, we rarely see a pancreatic NET that secrete hormone that cause any of the syndromes that I mentioned before, while when we're talking about pancreatic NET that are not in the context of VHL, the fraction of tumors in which there is clinical syndrome associated with them is much higher, ranging between 15 to 40%. Now, when we're talking about the pancreatic manifestations in VHL in general, we know that about 35 to 70% of the patients with VHL will have some type of pancreatic manifestation, with about or up to 50% of the patients will have pancreatic cyst, not neuroendocrine tumor. Only between 8 to 17% of the patients with VHL will develop pancreatic neuroendocrine tumors, and of those, up to 50% will have more than one PNET, pancreatic neuroendocrine tumor. From only 8 to 17% of the patients with VHL, those that have pancreatic NET, only about 10% of those will have metastatic disease. So we're dealing with a very unique situation, a rare disease from hippel-lindau with a non-common manifestation, pancreatic NET, less than 1/5 of the patient. And of those, only 10 will develop over a lifetime metastatic disease. And our objective is, of course, to avoid a situation in which patient already has a metastatic disease from pancreatic NET. And in order to achieve this objective, we need to know how and how often to follow the patient. We need to have some risk factors or risk stratification tools for the patient or for the tumor to know which patient will have tumor that has higher risk to metastasize, and then we'll follow him or her more closely or intervene earlier. And the last point is that if a patient already has a pancreatic NET, we need to know when we should resect it and how. And I would like to discuss this a bit more. Now, there is a very important point. Every medical procedure that we perform, any medical procedure, beginning with giving fluids in the emergency ward or a pill of analgesics, and on the other hand, we are talking about surgery, for instance. Every of these medical interventions have side effects. And if we want to take a biopsy from lesion in the pancreas, this also has side effects. This might be pain, infection, bleeding, and others. Now, if I see a patient that I know that has VHL, and I see lesion in the pancreas that has typical appearance and radiologic characteristics of pancreatic NET, I will never perform or almost never perform a biopsy or any intervention to verify the diagnosis, because the risk for pancreatic NET to begin with, up to 20%, is extremely higher compared to the general population. So if I already see a lesion that is typical of pancreatic NET, I won't do any intervention to verify it or to validate it. Now, this has the advantages of avoiding the side effects, but there is one weakness that I cannot look at the tumor under the microscope and see what is the grade of the tumor, how aggressive it is, and whether it has some characteristic of invading to other tissues or to blood vessels, etc. Now, we know that most of them don't do this, and when you weigh the risk and the benefits, there is a consensus that you don't need to do any biopsy in this situation. However, we need some indirect risk factors or risk stratification for patients with pancreatic NET. And during the last years, we have found, me and our colleagues, of course, that we found several risk factors, either positive or negative, for metastatic disease in patients with a pancreatic NET. And this includes the size of the tumor, the growth rate, the type of mutation, the type of change in the VHL gene of each patient, and even the blood type was suggested as a risk factor for the progression of metastatic disease in pancreatic NET. And small lesions, we know from several works, are associated with very low risk for metastatic disease. Now, when I was in the NIH, together with my colleagues, we thought that we can take the diameter of the pancreatic NET together with the change in the VHL gene, what we call VHL genotype, and try to merge this data in order to produce a more effective or informative risk stratification tool. And very briefly, we looked at the data on about 175 patients. And first, we stratified the risk for metastatic disease based on the lesion size. And we saw that those patients that had only a very small pancreatic NET, the cutoff was 12 millimeters, did not have any metastatic disease during the follow-up at the NIH. And those that had larger lesions, the cutoff here was 3 centimeters, had higher risk for metastatic disease. And then we saw that there was one group in between with lesion diameter between 12 and 30 millimeters. And we thought that for this group, we might use the genotype, the change in the VHL gene, to stratify their risk for metastatic disease. And this is what you see here at the bottom. You see the difference in risk for metastatic disease between patients with change in the VHL gene that's called a missense mutation. If you change in one letter in the VHL gene, a very localized change in the VHL gene, whereas patients that did not have missense mutation, none of them had a metastatic disease from the pancreatic NET, and before we included only patients that had a pancreatic NET. So when we applied our data from the genotype analysis on this intermediate risk group patient according to the diameter, we saw that we were able to identify almost all of the patients that had a progression of the disease during their time at the NIH. And based on our data, we proposed an algorithm for surveillance of patients with a VHL-related pancreatic NET, with patients harboring small pancreatic NET, smaller than 12 millimeters, with suggested follow-up every 2 to 3 years, and those with larger lesions, larger than 3 centimeters. We proposed to refer them for surgical intervention, and the intermediate group, we suggested to do VHL genotyping, or to use the VHL genotyping that's almost always already available, and to subgroup them to those with high-risk VHL genotype and low-risk VHL genotype, and to follow them in short or long intervals based on their risk according to the change in the VHL gene. And then we further analyze the risk of the high-risk group using more advanced genetic analysis and find specific loci or specific points or locations in the VHL genes that were associated with higher risk for progression or for metastatic disease. And then in 2018, another very important work was published. This is a very impressive and very important collaboration between Europe and Asia and the United States, led by Professor Neumann in Germany and Professor Kerry Seng in the United States. And they reported more than 2,000 patients with VHL, almost 300 with pancreatic NET. And again, they mentioned that the larger tumor were associated with higher risk for metastatic disease. And they also demonstrated that when you resect mainly the larger tumor, there is benefit in terms of survival of the patient. And this is very strong, very supportive to our findings. And they also identified this specific point in the VHL gene as posing higher risk for the patient for developing metastatic disease from the pancreatic neuroendocrine tumor. And I had a great opportunity and honor to lead a team of experts from Europe and the United States and Israel, of course, all experts in pancreatic NET and in VHL, and under the direction of Dr. Anthony Daniels, the head of the VHLA Guidelines Development Committee. We were in charge of writing the guidelines for the surveillance, screening, and management of the VHL-related pancreatic NET. And very briefly, we suggested the age range in which patients should be followed for developing pancreatic NET. We proposed the imaging modality and the way that this modality should be used to screen or survey for pancreatic neuroendocrine tumors. And the last thing, we defined the situation in which patients should be referred for VHL clinical care center. In general, we, of course, we think, all of us, that this is the best place to be followed at in general, but in case the patient is not able to come to VHL clinical care center regularly, then if one has a VHL-related pancreatic, he or she should be referred to a clinical care center. But definitely, if this is a large tumor, if the tumor is progressing, and if there is any suggestion or a clue for any metastatic disease from the pancreatic. Now, I would like to describe to you our collaborative clinic at Sheba Medical Center. When we established our team, the VHL team at Sheba almost 2 years ago, we set together all the experts in the fields of the kidney tumors and the ophthalmologists and the neurosurgeons and myself and the oncologists and everyone, we were together, and geneticists, and I'm for sure forgetting someone. But we discussed the way that we want the care that we want to provide to our patients. And of course, the first thing is to provide the gold standard clinical care according to the guidelines, according to the up-to-date literature. And the second thing is to help the patients that have to deal with the healthcare system throughout their lifetime to help them deal with the administrative issues and to save them as much time meeting us as possible. We planned a collaborative clinic in which the patient come and meet with me. I'm kind of coordinating everything and making sure that the patient is doing everything according to the guidelines. And then we're referring the patient to the ophthalmologist or to the uro-oncologist or to the adrenal specialist, etc. According to the findings in the imaging modalities, or refer to do blood test or imaging according to the gaps existing in the patient follow-up, again, based on the VHL Alliance guidelines. And above everything, we have amazing clinical case manager, Liat Arnon, which is in constant contact with the patient and makes an appointment and talks with the physician, making sure that everything works. And I really hope that the patients benefit from this, because this is very, very important for us to provide very, very good clinical care, but much more than that. And when we initiated the team, the VHL team at Sheba, we had one initiation meeting, and we call this Excellent Through Synergy. And every representative of the different VHL-related manifestations or fields gave an update on the literature, on the guidelines, on the techniques that he or she uses in the clinic, and I'm talking about the physician and the other VHL team members. And with great honor and pleasure to have Dr. Dassman with us that updated all of us on the proceedings in the clinical aspect and the scientific aspect worldwide. And of course, told us more about the MyVHL and encouraged us to encourage our patients to join the MyVHL with a great effort to collect all the data and identify more aspects of VHL that are not known yet and can be targeted or investigated more thoroughly in the future. And it is very important for us, in addition to developing and promoting the local activity in the field of VHL, to maintain the international relations and collaboration. First, because it helps us to keep up to date, and because this is the right way to work, always in collaboration. And we are taking part in the guidance development with the VHL Alliance. And together with Dr. Dhaval Patel, my colleague from the NIH, and with huge support from the VHL Alliance and the entire VHL community, we're currently writing the first comprehensive book on VHL. We already have some parts of it, and I hope that the COVID-19 will leave us alone. We'll be able to move forward more rapidly with that and finalize it quickly. We have collaborative research with Dr. Jacques Izard that gave excellent talk here in the Meet the Researcher 1 or 2 weeks ago. And we're working on unravel additional VHL manifestation with his Dr. Izard amazing bioinformatic and scientific tools. We had an international school for multiple endocrine neoplasia syndromes at Sheba on January 2020. And we had a very interesting session, very informative session on VHL with many specialists from around the world on VHL and on other syndromes, including Dr. Anthony Daniels and of course Dr. Eric Jonas and many others. And it was, I learned a lot from this meeting. And we also consult patients from other countries, neighboring countries, with or without diplomatic relations with Israel. And I think that it teaches us, we help to the extent that we are able to. And this is in terms of our international contacts. And this is the first international school that I just mentioned. You can see some of the participants, here Dr. Daniels, Dr. Jonas, and some others. You can see all the faculty here in the audience, of course, and we hope to have another meeting, the second school for men's syndrome in 2021. But we have to see again whether we have any flights from around the world to Israel by then, and we'll send an update on that as soon as we know. And there are many, many people involved in all the activities that I mentioned. First and foremost, the Shiba VHL clinical care team, the Arnon, which takes care of all the framework, all the network between us, and all the physicians that are involved in the work. I have an amazing multidisciplinary team for neuroendocrine tumors, surgeons, and of course, oncologists, and from the different type of imaging modalities, functional anatomy, and they are all involved also in VHL, and they help us identify the different lesions and to decide on the right time to intervene. We are doing the VHL-related research at my lab, with my lab team, and I owe a lot to Dr. Constance, who taught me all the basics and more than the basics on genetics and conducting research, and my team at the NCI. And this is, of course, the VHL Alliance Guidance Development team, the Dr. Anthony Daniels, that led this project in an amazing way with great leadership, and my colleagues in the pancreatic manifestation subcommittee. And last but definitely not least, the VHL Alliance, Dr. Tasman and Dr. Yona from the clinical aspect, and Mr. Mann that is here with us, and Heidi for your amazing work throughout the year in all the aspects of VHL, of promoting the awareness to VHL and for promoting the cure of cancer through VHL. And mainly for patients and their families that trust us and advise us how to develop the VHL care and to be better in many, many aspects. And that's it. Thank you very much.
Thank you so much. That was amazing. Okay, so we have a few questions for you. We could start with, how did you become interested in VHL research and specifically neuroendocrine tumors?
Okay, so these are two different separate questions, because I became interested in neuroendocrine tumors while I was in my fellowship in endocrinology. It always starts from a patient, always. A patient with a metastatic neuroendocrine tumor, and that was the main way that I learned about neuroendocrine tumors at the beginning, and that's why I decided to move forward and go to the NIH to learn about neuroendocrine tumors. And when I came to the National Cancer Institute, to the endocrine oncology branch directed by Dr. Lekton Kibebu, he offered me to learn more about VHL and to analyze the data from the VHL research, together with Dr. Nilobu, Dr. Patel, and my other colleagues at the branch. And that's why I learned about, that's why and how I learned about VHL. And interestingly, I found out that one of my patients that I'm now following, I met before I went to the NIH in Israel at during my fellowship, and we did a kind of reunion after I came back to Israel. So I closed several circles, but the way to neuroendocrine tumors in VHL were slightly separate.
Wow. So I guess going on to the research that you're conducting, what are the implications of your research on the everyday lives of VHL patients?
So the simple, okay, this is a quite complex question. It's very hard to compete with the advances in the field of VHL these days, because in recent years there is amazing progress, mainly of course in terms of the histamine inhibitors and the clinical trials. So everything that we are doing in the field of VHL-related research is always a second level compared to this amazing move forward in the treatment of VHL, and this is great news for our patients. The research that I'm doing in my lab with my team is mainly VHL genetics and some more advanced type of genetics, what we call epigenetic changes of the DNA in patients with VHL. And this is more relevant for the diagnostic aspects of VHL. And I don't think that it will have impact on the life of VHL patients in the next few years.
Why should people outside of the VHL community be interested and support your research?
First, because we're doing amazing research, we're best in the world by far, so there is no question about that. But apart from that, the reason is that in research, much more than the topic that you are dealing with, the methods and the tools that you are using are very important, because you can apply them on one field and then you can apply exactly the same tools on another one. Just as an example, something very recent, we are using tools to identify a certain type of cells in tumors. By taking data, genetics data, we use some type of bioinformatics and computational tools to identify these cells in cancer. And we use exactly the same tool to identify this type of cells in blood of patients with the coronavirus. You believe it or not. So you can use tools that we are using in cancer in our lab every day on one field and apply them to infectious disease. So I think that the tools that we're using are state of the art in terms of the bioinformatic level and the scientific product of them. And I wholeheartedly believe that will advance science in the very, very short time period. And we have several publications and results that are very interesting and definitely worth support.
Here are a few specific questions to treatment. If a pancreatic neuroendocrine tumor has metastasized to the liver, what are the treatment options and what kind of prognosis would you be dealing with?
So this is a very good question. And the problem with the rare diseases is that we don't have enough data to answer this based on results of studies. In medicine, or Western medicine, we want to answer according to research that has already been performed and even better performed twice, what we call validated. And we don't have much data because this is such a rare situation in metastatic pancreatic NET in patients with VHL. So I can answer, but replying based on non-VHL-related pancreatic NET, and we already know that these are very different. So in what was sporadic pancreatic, the non-VHL tumors, the tools that we have range between medical intervention and kind of injection once a month. This is not chemotherapy, this is type of biological intervention or drug. And we can give a specific radioactive compound that goes directly to the tumor cells. We do it regularly in a pancreatic NET that has metastasized, not in the context of VHL, with very much success. And we can have intervention directly to the liver and combine this with surgeries for some extent. So we have plenty of options for intervention for patients with metastatic pancreatic.
We have a question here, Dr. Tirosh, about the cytostatin therapy and how it might be used to delay surgery in somebody who has PNETs that are under 2.5 centimeters.
Again, great question, but I don't have answer for that. There is there is some progress in the understanding of treatment of pancreatic NET in the context of hereditary syndrome. So we know that the pancreatic NET in another syndrome called MEN1, they may benefit from treatment with the same drug that you mentioned, somatostatin analog. This is the sandostatin, and this may delay the development of advanced disease or metastatic disease. However, we don't have this data in regard to VHL. I want to say one thing. This is not exactly what you asked, but it is important to mention this. Neuroendocrine tumors tend to develop on their envelope, what we call the membrane of the cells. They can present a receptor that can bind some compounds that go in the circulation in the body. And one of them is a somatostatin, which is present in the human body, but we can use an imitator that we call somatostatin analog. This is a drug. This is the injection that can be provided once a month, the somatostatin analog. And this is the sandostatin that you mentioned. So in neuroendocrine tumors in general, we know that we can give patients a somatostatin analog in most of the tumors, and this can delay the progression of the disease. And because the tumors in the context of VHL almost always present these receptors, the chances that they will bind this somatostatin analog is very high. But still, I cannot tell you for sure, although the gut feeling that yes, it may have some effect. As a clinician, as a scientist, until I have a strong evidence that it really had an effect, I cannot tell you that I'm sure that it will have any benefit.
Thank you. And one final question for you, Dr. Tirosh. What are the side effects and symptoms of a large pancreatic cyst? And is there any risk if they're left to continue to grow?
So, again, a very good question. So it really depends on the location of the cyst and whether the cyst causes any pressure on the duct that goes in the middle of the pancreas, on the outlet, the point where the duct is merging with other structures. And it also depends on whether, what percentage of the pancreas is involved by cyst. If the cyst is causing some pressure on the duct and blocks the stream or the flow of the pancreatic fluid, this may cause some types of pancreatic-related diseases or acute problems. If the pancreas is completely involved by cyst, then it is completely non-functional, and then a patient may develop diabetes and maldigest some part of the food that he or she consumes. And there may be bleeding into one of the cysts that may cause pain, etc., etc. But every patient with any type of symptoms that is suspected as involving the pancreas should be considered separately, and the imaging should be inspected and analyzed, and decisions should be made on a patient basis. But you cannot set a rule for all of them together.
Dr. Tirosh, thank you again so much for taking the time to join us today, for all of your hard work on the VHL guidelines, and for everything you're doing for your patients, especially the VHL community. We really, really appreciate it.
Thank you. Thank you very much. It's a pleasure to be here.
Thank you. And for everybody watching at home, please join us for future Meet the Researchers, as well as other Surviving and Thriving Together events and VHL Awareness Month events. You could find a calendar of events at vhl.org/together and at vhl.org/mayawareness. Dr. Tirosh, thanks again for joining us.